Good evening. I want to thank all of you on behalf of the entire panel for joining us this evening to talk about this important topic. So to start off with, I want to be sure we're all on the same page discussing sexual assault. According to RAINN, which is the Rape, Abuse, and Incest National Network, the term sexual assault refers to sexual contact or behavior that occurs without explicit consent of the victim. Some forms of sexual assault include attempted rape, fondling or unwanted sexual touching, forcing a victim to perform sexual acts such as oral sex or penetrating the perpetrator's body, and penetration of the victim's body, also known as rape. So when we are talking about sexual violence, it is important to note that every 68 seconds, an American is sexually assaulted. More than 1 in 3 women and nearly 1 in 4 men experience sexual violence involving physical contact during their lifetime. For children, 1 in 4 girls and 1 in 13 boys experience sexual abuse in childhood. Hearing these statistics, it is apparent we need more nurses trained to work with patients who experience sexual violence. HRSA provided training grants to agencies across the US with the goal to increase the supply and distribution of qualified nurses working as sexual assault nurse examiners, or SANEs, and expand access to sexual assault forensic examinations. VUSN received training grants from HRSA, and 2 of our trainees are participating in this meeting today. So the first question we have is, why is this important for everyone to know about sexual assault, and what are the lasting effects? And this is going to be for Beverly and Sarissa.
Well, thanks so much, Pam. I think, that is such an important question for all of us to really take in and realize when you hear those numbers and the statistics behind the frequency of sexual violence, understanding that we are dealing with a patient population that has more than likely experienced some type of sexual violence or sexual abuse in their lifetime is quite possible. So I think as providers, as nurses, that we as a whole have the responsibility to understand the prevalence and the impact on our societies, and then we have an opportunity to do something about that. I think with understanding that prevalence, it's really important for us to be able to know that we have an opportunity to support survivors at any stage that they're in. So while today we might be talking a lot around the crisis stage and immediately following a sexual assault, that sometimes these effects last a lifetime, and sometimes they don't. Each person deals with this situation in their life in their own way, but we have an opportunity to support survivors by believing them, by listening to their stories, and to fully understand within ourselves, and to really teach that they are not responsible for the sexual violence that occurred. And I think by doing this, that we can contribute to a society that holds perpetrators responsible for the violence and holds perpetrators accountable for their behaviors and actions. And because so many people may not seek services or help right away or very specifically for the sexual assault, we have the opportunity to provide that type of support and referrals for further resilience and healing in a patient's life.
Absolutely. Very well spoken, Beverly. And as Beverly stated, the impacts can be a lifetime. And I think now the conversation is more prevalent and there's more openness and support related to sexual assault. But in my experience currently working with a geriatric population, oftentimes I might be the first person that's been told by this, that this has happened to them, and it happened as they were children. And so, the individual might be in their 70s now. And so because there was not the support back then, or even now, there's a lot of shame associated with it and a lot of hiding. And oftentimes people don't realize how much it has impacted them until they're able to release their story. So as providers, as Beverly stated, I think it's very important for us to create those safe spaces, create that trust between us and the client, because we never know when that might open the door for someone to begin their healing journey.
That's great. So Heather, this question for you. What does human trafficking look like?
So as we've kind of talked about a little bit, we've really talked around sexual assault and what that looks like, but I don't really think that you can talk about this category without really diving into human trafficking. We hear a lot about it, and a lot of times we think, oh, that's happening in other countries. It's maybe not happening here in the United States, but it's happening elsewhere. I'm going to tell you that it is happening right here, and it's happening in your backyards. It's people that look like you, that look like me, that look like just your average everyday American. Human trafficking is using fraud or force or coercion, and it involves either a sex act or it can also involve a labor act. And then it dives down even further into what we call CSECT and DMST, which stands for Commercial Sexual Exploitation of Children and Domestic Minor Sex Trafficking. And again, that those pieces involved a sex act, often through force, fraud, and coercion. Millions of men, women, and children are sexually exploited worldwide. Like I said, we kind of think about it as more of a global or a national problem, but not really happening here. It happens in every community, and it takes on victims of any age, any social status, race, gender, nationality. And these traffickers use forms of violence and manipulation, false promises, romantic relationships in order to lure in victims. It's around 40.3 million people are actually enslaved. We call it modern day slavery now. And 1 year old is the actual youngest victim of some form of cyber trafficking. 1% of the victims actually survive from trafficking. So that means 99% don't survive or they never go home. 80% do not receive any help or resources in helping for their recovery. So that's been really daunting to me. And what it looks like, especially for our nurses, especially that are out here or that work in emergency departments, is I'm involved in a human trafficking organization, which I'll talk a little bit about later in the panel. But one of my girls told me that she appeared in the emergency room 6 different times before she was even identified. So knowing kind of what the red flags are, they're not going to talk about it. They may come in with their perpetrator who does all the talking for them. There may be signs of abuse, but they're hidden. Could be branding, tattooing, different kind of things. So I don't think we can even talk about sexual assault without bringing in this piece of trafficking. And one of the most important things I leave you with trafficking is that it's such a worldwide problem. It's a $150 billion industry, and you can sell a kilo of Coke once a night, and you can sell a trafficked girl 7 times a night, 7 days a week.
Thank you, Heather, for that important information. So the next question is for Aaron and Sarissa, and it is, what are the signs someone is hiding that they are being or have been assaulted?
Well, speaking in the world of children, I think it's important to know that 90% of children that experience sexual abuse know and have a relationship with their abuser. So we push kind of the stranger danger thing from the time that kids are little. But the main issue lies within family members. It's a step parent, a grandparent, a cousin, an uncle, an aunt. It's people that they love and that they know have a relationship to their family. So a lot of times they are kind of bribed to keep a secret because there's kind of a guilt trip laid into children about what they will lose or who will go away if they tell that something happened. It often starts with grooming too, when they're little and they start touching them in places or making comments that are inappropriate, and it grows. So children don't always really know what's happening until it's been going on and they feel like they've been complicit in the abuse. So what that looks like for kids in the acute setting, or when something has recently happened, is they might suddenly be really fearful of bath time, or be really curious about, overly curious, not normal childhood curious, but extra curious about touching or seeing other people's private parts, using sexually inappropriate language that you're not sure where they got it from. And then as time goes on, they might behave like a normal child and you might not have any idea, but they have this really overwhelming desire to keep the family together, or they talk about secrets that they're supposed to keep. That's a big one. When somebody tells them to keep secrets, they say, yeah, secrets are things that you don't tell people. A lot of times children will do what we call a testing the waters disclosure, where they might start making comments to people to see how they react. They might start talking about somebody else that's not them that has been touched, or they might give you a small piece of information like, Uncle Joe touched my leg, and see how you respond to it. And then if you kind of ask a little further, they might give you a little more. If you react in a way that tells them, oh, you're telling stories, or stop lying, or stop joking, then they shut down because they realize that you're not going to believe them when they tell you the rest. And that's how, you know, it gets protected for a really long time. It is difficult in children though, because there are some myths that children that, you know, wet the bed or suddenly are regressing means they've been touched. And that's not indicative at all that they have been touched. Now they might wet the bed and also have been experiencing sexual abuse, but the two don't necessarily, they can coexist, but one doesn't indicate the other.
Sure. And the other thing that I might add is I think it's important for us to know that we need to use the correct language around students or kids' body parts, because sometimes they might be telling you something, you know, like Uncle Joe touched my cookie, because we use these sort of interesting names to describe our body parts because we think vagina or penis might be inappropriate for children. And, you know, I've heard of stories where children have disclosed certain things to an adult based on the nickname for that body part, but they're really trying to tell you that they're being sexually assaulted. So definitely using the correct names and just listening for some of those codes that we may not think of as being detrimental.
So we're going to transition to SANE training right now. So the first question is for Stacy, and it's, why did you become SANE certified?
Sure. So I actually started my undergrad in biochemistry, hoping to work in forensics someday, and life changed, and I ended up in the nursing field. And I remember in my associate program hearing from one of my professors that forensics was an option as a nurse, and it was immediately intriguing. And I remember I'm going to tuck that away for this point and come back to that later. And, you know, when I started my emergency nurse practitioner training at Vanderbilt and was presented this opportunity, I knew I had to take it. I feel that as nurses, we always tend to step in to a role, especially when there's a great need for it. And despite having, you know, a full SANE response team, it doesn't always seem like you have it when you need it, or there's enough, or we can always use more. So it was a really great opportunity presented to me from Vanderbilt, thanks to the grant. So that's why.
That's great. So Erin, what are some settings of care?
Well, I know in general, SANEs will be employed in hospitals, outpatient medical facilities that are kind of an extension of the hospital. We have children's advocacy centers, which are standalone kind of government funded agencies. There's SANEs on school campuses. And then we also have them in the rural setting of like Indian reservations. Definitely not in enough places, it doesn't always seem like. And then when we actually have to perform these exams, we typically do them in our office. I work at a children's advocacy center. We have all our equipment there. So if possible, we always like to get the child to us. It's more child friendly. It's not, you know, quite so white coat scary to them. We also do the exams in the hospital emergently if we need to. And in Florida, where I work, we actually even have these hurricane kits, because during hurricane season, you never know when an emergency is going to come in, and we can just take, you know, the bin and have it portable to do wherever it needs to be done. If there's evidence that needs to be collected and exams that need to be done. I know my colleague actually did an exam in a police station one time. So they're everywhere and not enough places all at the same time.
Nurses are adaptable, that is for sure. So Heather, if you could talk about the certification process.
So there's a couple different ways to do certification, and it's kind of a lengthy process. There's nothing we do in the nursing world, I don't think, that doesn't take a lot of lengthy processes, but we just want to make sure that we have the credentials and the pieces to be competent at what we do. So there's two different organizations. I'm going to talk a little bit about both. There's the IAFN, which you'll hear me refer to, which stands for the International Association of Forensic Nurses. And then there's the AFN, which is the American Academy of Forensic Nurses. And I'm going to talk a little bit more about IAFN because that's the one we hear about most readily. And there's a couple different ways to go through certification. So the first piece of the puzzle is to identify or to hear about it somewhere that you want to do it, because most of the time we're not hearing about SANE until we get into schools and other places, or, oh, I can do forensics or things of that nature. Just as Erin had said, or as Stacy has said, that she kind of heard about it and then put it in the back burner. And a lot of us started off that way. But with the certification process with IAFN, for example, you go through a 40-hour didactic training. And for some people that's done in an online space. IAFN has it online, but there are other places in different states. For example, I'm in Georgia, and through the Georgia Network to End Sexual Violence, they do a 1-week-long 40-hour didactic training. And that's where you learn everything around the processes around sexual assault, what the exam looks like, what you will do as an examiner, etc. And then the next step is to actually go through the clinical component, where you do a particular amount. It really depends for people. Some may do 20 hours. If you're a nurse practitioner, you may do less because you have the skill set of knowing how to put in speculum exams and you're just learning how to swab. So there's that clinical component that goes with that as well. Once you go through the didactic and the clinical component, then you need to have about 300 hours before you can sit for certification. And the way that it looks is there's two different types. Well, actually, there were three. Now there's two, but we're coming back out with another way to certify. So there's the Sexual Assault Nurse Examiner A, which stands for Adult Adolescent, and Sexual Assault Nurse Examiner P, which is for Pediatric. And basically the way that they are different is the pediatric is going to be more for the younger prepubescent patient. Usually I kind of give that gamut under 12, where the sexual assault adult adolescence is often going to fall 13 and above for how you're going to see them. And of course, you can have both of those. Even if you are a registered nurse, and you can still get both of those trainings, that actual certification is for registered nurses. But someone like me, who's like a women's health nurse practitioner, I actually could get both of the certifications as well, even though I don't do peds as my women's health world. But because the SANE piece of it, the A and the P, is an RN related role, you can wear both of those titles. And then the other certification that they used to have was the Advanced Forensic Nursing, or AFNBC. And that usually went to people that were nurse practitioners, had a master's degree, or were advanced in their field. They've gotten rid of that credential, but it's actually going to be making its comeback, and it's coming through the that Academy of Forensic Nursing. So more on that will be coming to play. But again, both of those organizations, IAFN, International Association of Forensic Nursing, and the American, or the Academy of Forensic Nurses, are your two ways to look at it for certification.
That's great. So Sarissa, how does the mental health nurse practitioner fit in?
Sure. You know, in my practice, clinically speaking, I've seen where sexual assault is highly prevalent. And so obviously there's a lot of shame and guilt and mental health impact that patients actually experience. And so as a mental health clinician, it's important to build that therapeutic alliance. Sometimes these patients are at risk for developing mental health disorders, and doesn't necessarily have to be PTSD. It could be depression, it could be anxiety. And so building that therapeutic alliance is important in determining what type of intervention would be needed for that particular patient. So from my aspect of things, of course, I prescribe medications, but there are many types of therapeutic modalities that people use to treat sexual assault for children. We use a lot of times trauma-focused cognitive behavioral therapy. There's EMDR. There's cognitive processing therapy. So there are many types of therapeutic modalities that we can use to help individuals heal and work through the traumatics aspect of things, in addition to the medication. I think the evidence shows that the best outcomes are achieved through medication in addition to having the psychotherapy.
I think the important point with all of that is that this is not a singular instance and a singular way of treatment, and it's not a singular discipline that can address the needs of these patients. There needs to be a team that is surrounding these victims of sexual assault and trying to make sure that all of their needs are met, because they're so complicated. So the next group topic is talking about SANE providers. And I wanted to talk about the fact that, you see the panel, but that males can also be SANE providers as well. Now in IAFN, I reached out to them. Heather talked about that organization, and they said out of their 6,000 members, 50 of them self-reported as male, but these are certified SANEs within IAFN. So it's a smaller number, but that doesn't mean that they're not providing services to the victims of sexual assault. And so this is definitely a role that men can get involved and stay involved and provide these services. The IAFN is actually holding a discussion on December 7th of this year that's talking about the role of male SANEs in providing services to victims of sexual assault and what that looks like. So if you have more interest in that, that might be a good discussion for you to join. So the next question is, what are the differences between being certified for pediatric versus adult? And then Heather was going to answer that. I think you kind of touched on that.
Yeah, I touched on it a little bit, so I'm not going to get into it a whole lot again. But again, there's the IAFN that credentials you with the SANE A for adult and adolescent and the SANE P for pediatric. And the biggest difference is the population. So the P for pediatrics is going to be more around the prepubescent child from birth all the way through around 12, 13, but they can see them all the way up to 18 because they still fall in that range. So they gap a little bit with the adolescent. But then where the adult adolescent comes in, because you can take the adolescent in, is usually from 13 onward to death. So there is a little bit of that gap in between that 13 to 18, where both the adolescent, adult, and the peds can also work with that population.
So if Stacy and Beverly could talk about the advantages of an APRN being a SANE and impact of a SANE on outcomes, that kind of thing.
Sure. So while I don't believe that being an APRN has any specific advantages as far as patient outcomes, in that we're all trained the same, we go through the same rigorous training of the 40-hour didactic, you get the same, clinical hour requirements. However, and trauma-informed care is part of that training, evidence collection is part of that training. I don't believe that being an APRN provides an advantage in that aspect, but I do believe it does provide an advantage when it comes to continuity of care, especially from an emergency department standpoint. As a SANE provider in the emergency department and a nurse practitioner, it allows me to treat the patient from the moment they come in the door, assess any emergent conditions that the patient may need to be treated for, as well as continuing their care through the same process. So I think that it provides patients a level of continuity that rather than tell their story multiple times, rather than them feeling exposed or vulnerable to multiple providers, I think that definitely helps with, overall patient continuity. I can't say that, that there has ever really been any significant evidence to say that APRNs provide a better outcome for a patient. I think that RNs are, they provide very, effective and fantastic care. As far as, the other thing is, APRNs are allowed to, we can do their whole prescription. Follow-up care is not necessarily something that we would continue on in an emergency department setting, nor is it something that we typically do in the Children's Advocacy Center unless we have very specific concerns and have to bring a patient back to the center. So follow-up is almost always deferred to a primary care provider from either standpoint. So I don't believe that, in the follow-up realm, APRNs, would provide a specific, unless it's a very, distinct case with, specific circumstances, in which case you'd have to bring a patient back to your center. As far as the hospital goes, we wouldn't do the follow-ups either.
And I think, Stacey has a good point there. I've worked in an emergency room at both as an RN, as a SANE certified RN, and then again as a pediatric nurse practitioner. I think, the key difference there is that continuity of care. And I think a big piece for me, once I was working as an advanced practice nurse, was just that knowledge base of differential diagnoses with your pediatric population, because a lot of times you're seeing kids so much later after the fact, you're not necessarily collecting evidence. And so, I think those are some of the key elements that I didn't necessarily learn as a SANE that you're not going to learn in a 40-hour didactic course. So I think that is, one of the benefits of seeing, the chronic sexual abuse patients, or the ones that have disclosed so much later after the fact, and being able to, walk patients and families through any lasting physical or medical impacts, I think was just advantageous as an advanced practice nurse compared with my training as an RN.
Great, thank you. So if Beverly and Heather could talk about the work they've done on a large scale.
Yeah, it's so exciting to see Vanderbilt get that HRSA grant. I actually had a job at Indian Health Service headquarters as a result of some funding that was provided by Congress over to Indian Health Service to start a national training program. And so I was hired on as their national, at the time, my title was this National SANE SART coordinator. So I had an opportunity to walk in to Indian Health Service at the headquarters level to develop national policies and develop a national training program. So back in 2012, 2013, we were rolling out online didactic courses. We were really unsure like how well this was going to take and how well it was going to work. It's really exciting to see that this many years later that this is a standard that as nurses we're being trained, online through these virtual courses. I think one of the pieces that I have to say I'm most proud of is being part of a national effort to develop a clinical skills training lab. So when nurses are coming through for their SANE training, what we didn't want to see happen was their very first exam on a patient, on a live patient that they had not worked with before. And in these rural communities and on Indian reservations, a lot of times that's, you've taken your 40-hour course and the first patient you're going to see, that you have the most training of anyone. And so we wanted to try to prevent that. So we created this clinical skills lab in Colorado Springs, Colorado, and it was a 2-day course. And they were able to go and be trained. Their professional patients were there with a whole case scenario. They could collect evidence and do a complete speculum exam, full head to toe, collect an evidence collection kit, and just work out your nerves and how you speak to patients and everything that's just nerve-wracking, because sometimes in those situations you're just so focused on getting everything right, collecting the evidence the correct way and not messing up. So it really puts you in a live environment to be trained. And I think, that was an incredible opportunity to be part of, to build the competency of people that were going back out into the field. And then we know that a lot of times in rural communities, there's just so much reporting that you're not going to see a lot of patients. So that type of skills lab was so important. And I think, weaving that back in, knowing that When we, Indian Health Service, had a need here in Nashville to train nurses, we were able to go to Vanderbilt and work with Vanderbilt on their clinical skills lab and have that same, recreate that same type of training program. So I just have to say, my national work with Indian Health Service and then seeing Vanderbilt just really be a leader in that is a phenomenal way for those that are on with us tonight to hone your skills and know that you just have a great opportunity to get some awesome training that you will most likely in your career put to use.
So I'm going to kind of jump in exactly where Beverly said. Like, it's so amazing to see my institution where I'm an alumni from get this grant. Like, I could go on and on how awesome it was to see it. So I graduated back in 2001, and I actually went through the SANE didactic training in 2000 before I ever went to Vanderbilt. I was in a school getting my nursing degree. They had a forensics track. They were trying to build the forensics, but forensics just became an accepted field by ANA back in 1995. So when I went through this didactic training in 2000, now I'm like, okay, what am I going to do with this? I'm heading off to Vandy. I'm going to be a nurse practitioner. Maybe I'll use it somewhere. So kind of like Stacy's calling almost, I was like, all right, I'm just going to put this in the back burner. I did this didactic, and it's always going to probably sit on my heartstrings. Great training, but I don't know what I'm going to do with it right now. So went through all my training. It wasn't until, and we were a military family, so we've moved all over. I've lived in many places, worked as an NP in many different settings. And when I got finally back here to Georgia back in 2013, I met someone through teaching at a local university, and she started she was the sexual assault nurse examiner. I'm losing my train of thought, but she was the head person for a little center here in our Marietta, Georgia area. She came and did a lecture, and right afterward, I was like, okay, I need to meet you. I did this training like 10, 15 years ago. What do I do with it now? And so I went back and did the training again for didactic, because you can go through this so many different times and learn so many different skill sets. And long story short, I worked in a rape crisis center on top of working as a women's health nurse practitioner. I always kind of had a cross between patients that came to see me for trauma or sexual health or concerns, and my niche really is sexual health. I was finding more of that trauma piece and wanted that training. So the Rape Crisis Center fit in beautifully. But what happened is this amazing person I met, who was our sexual assault person in our little Marietta, Georgia, left to become the statewide SANE coordinator. So she still is our SANE coordinator for Georgia. And we had grants that came through through our state, and it was a huge initiative of the First Lady of Georgia, Marty Kemp, around human trafficking. And so there was a huge funding, over $1 million, that came into Georgia to help fund a human trafficking center. And that's something that's always kind of pulled on my heartstrings. It's something that's always aligned my work that I did as a child with my mom doing philanthropy for child abuse and neglect, with my women's health, with the SANE. It was kind of all my worlds colliding. So I got asked to build the medical component for this program. And we are the first of its kind. We are an emergency stabilization center in Georgia, where we offer a couple different pathways, where it's a 90-day emergency stabilization for male, female, and transgender youth. And we see them through medical, educational, mental, and life skills over their 90 days. I've been collecting data in our center since our opening in 2020. We opened March, literally right in the middle of COVID. The world shut down. We opened basically a week later. We've been through pandemic craziness and staffing shortages. We've seen it all. But it's been an amazing opportunity. And just to know that, I feel like I always kind of come in now as that trafficking person, like, hey, we're going to talk about sexual assault. Don't forget trafficking. Don't forget trafficking, because it is such a worldwide problem. And so what I'm trying to take is our program and make it more of a model so that it can be used in other states. And so we're going to be writing and disseminating on that.
That's great. That's from both of you. That's really terrific. It makes me so proud to be part of this panel. So the next topic we're going to talk about is practice. And so we're going to ask Erin to talk about what does the exam include, and if she could dispel any myths about sexual assault exams.
Yeah, so the majority of the exam is really the history collection. I'm creating a rapport with the child. I'm making them, feel comfortable. I'm learning about them, where they're at developmentally. And then I kind of get the history of what happened. And we like to compare it a lot of times to somebody that comes to the doctor with ear pain. I'm going to ask when it started and what things might make it worse. What does it feel like? How long does it last? Does it come and does it go? And that's kind of the same thing in regards to where somebody's touched them and when it happens. So I use that history to kind of guide my medical exam. I know what areas of the body I'm focusing on. If it's an acute exam, I'm going to do some evidence collection first. So we're going to swab the areas of their body that have been touched for DNA if it's within that, 108-hour window. And then we're going to check for injury and any signs of infection. So with kids, we never use a speculum. I know there's some practices that do, and when they get into teenagers, but there's not really any need for us to do that at the Children's Advocacy Center unless I'm concerned that there's some serious internal injury. And at that point, I would send them in to the hospital anyway. But I first do my evidence collection. I then do my genital exam. And then I spend a lot of time either doing a pregnancy test, giving them prophylactic antibiotics to prevent infection, getting them tested for sexually transmitted infections, and then a lot of reassurance about their bodies. The exam itself only takes really about 10 minutes, I would say. The rest of it is a lot of, reassurance and education and follow up if it's necessary and providing that support. We make referrals for counseling for them and family advocacy if the family has needs that isn't being met, like financial issues, issues with food, things like that. So we're kind of assessing them as a whole at that time. Now, in terms of myths of the exam, I'd say that one of the most frequent things I hear is the question of, am I a virgin? Or can you tell? They think that there's a virginity test, that cherry popping myth. Like the first time somebody touches you or something happens, something pops and you can see and your hymen was intact and now it's not. And that does not exist. That hole is open forever and always when you're born till when you die. And sometimes there can be some tissue tearing and the injuries that are indicative of acute assault, but even injury is rare to see because it is normal to be normal. That part of your body is made to stretch. And even if there is injury, it heals very quickly. I had a child that came in that had injury and I followed up with her the next day and it was healed. So it is pretty quick and amazing what the human body can do in terms of healing itself. There's a lot of moisture and blood flow to that area. With children too, a lot of times their perpetrators are people that want to be able to keep touching them. So they actually will not hurt them because if they hurt them, they know they can't keep doing it. So it is very normal to be normal, especially in kids. The exam itself is also not painful, typically, unless there, is some significant injury that's causing some burning. But a lot of times people think that it's a long, drawn out, painful exam where people are poking and prodding around that area. And that's just not the case. It's pretty quick. It's mostly visualization and the swab collection. And then, the majority of it is just talking to them, making them feel comfortable, making them feel supported.
I'd never heard somebody make the point about the normal and how the perpetrators don't want to injure their victims. I've never really conceptualized that before. So that was really impactful for me. So for Heather, what happens after the exam and what are the next steps for the patient?
So I think it depends. I think it depends. Is it in an inpatient facility, like a facility like mine, an emergency stabilization place? What does that look like? Or are you going to a rape crisis center or a child advocacy center where it's just outpatient and they come in? So in my facility where I am inpatient, the next steps for them is to get acclimated into their milieu, where they're going to eat, where they're going to sleep, to meet the other teenagers that are there, to meet the staff, to learn kind of all the dynamics of the center. When it's more of an outpatient setting, one of the things I do at the Rape Crisis Center for follow-up after the exam is, as soon as I finish the exam, once we're done, I get them back to where they're kind of clothed in over a sheet or whatnot, so that we're kind of on that same playing field. Ask them, are there any kind of questions or concerns about the exam? We ask this all along the way, but anything as follow-up. And then for us in our inpatient center, the next thing I say is, do you want to go take a shower? Because we have an amazing shower and a bathroom right there for them. Because most of the time when they come to us, especially if they've called and they've come through the police or through law enforcement or U.S. Marshals or anything, the one thing that we haven't talked about in here, but we always say, don't have them shower, don't have them wash off, stay in the clothes that they were in, get them here immediately. So oftentimes when there has been a series of abuse, assault, whatever that may look like, patients feel awful and gross and they're in these clothes. So one of the best things that I can offer for them, and I tell them this immediately, is, you know what, we're going to get through this exam. We're going to ask a bunch of questions. You can ask us questions, but the last piece is that you get to shower and you can take your time, and we have nice billowy towels for them. And that's kind of what it looks like from an outpatient setting. The other thing that we have in an outpatient setting, which is what you're most commonly going to see, is usually some sort of advocate that works with the patient. So in our outpatient center, there is a rape crisis advocate. Every time an assault is called in, a sexual assault, a SANE comes in, as well as the advocate. The advocate stays with you for the entire time of the exam, kind of acts almost like a chaperone of sorts to the SANE, even though the SANE's doing all of the swabbing and pieces of that. But then they're helping the victim, asking questions, getting them into care, giving them follow-up care, which is a lot of times mental health services, getting them in possibly to their primary care providers, to the health departments or things, if you're in a center that doesn't do like follow-up sexual STI testing. So a lot of times we'll treat them prophylactically, but they want to come back and make sure that everything looks okay. So that's part of those pieces, is what that looks like in the aftermath. And basically the next steps for the patient is really trying to give them back that sense of control and the sense of power, is to tell them, again, as we've all said throughout this whole panel, it's not their fault. They didn't do anything wrong. To let them understand that we are here for them along the way, that they may have feelings that they may be completely numb and not know what's kind of going on in that moment, because it's that fight flight response kind of kicking in. But when they settle down and maybe go to sleep and wake up the next couple hours or the next morning, they may have this vivid picture of everything that happened. And that's when some of that psychological and emotional trauma can come into play. And so giving them the resources and having the numbers so that they know that they can get the help that they need.
Great. So the next question is for Sarissa, and it's, how does the mental health practitioner help in this circumstance? Oh, you're muted, Sarissa.
I was saying that Heather gave a beautiful segue in that the mental health practitioner is part of the next steps for the patient. And I want to say that there is no monolithic way that individuals express themselves, or even if they've experienced sexual assault, the mental health implications can present very differently, depending on the age, depending on the circumstances. And so it's important to really get the accurate assessment. And then even if I know that the individual has experienced a sexual assault, I don't make them recount the details in the initial assessment, because they may or may not be ready to do that. And oftentimes, if it's our first encounter, we certainly want to build that trusting relationship before we do so. And so I think the most important part is, again, building that therapeutic alliance, and then addressing the immediate needs, which sleep disturbance is often very common. And so that's something that we can address immediately, typically, whereas anxiety or depressive symptoms or PTSD symptoms may take a while. So again, prioritizing what are those immediate needs, but then coming up with a plan that will work, because oftentimes when individuals come into treatment. If it's acute needs, then, it's different. But if they've been suffering for quite some time, just kind of setting their expectations in terms of what's going to happen, in that agreement, and respecting whatever their wishes are. Sometimes people do not want to talk about it yet. And, they want to address other things. And then sometimes they want to talk about it right away. So I have seen individuals right after an event, either pediatric or adult, but I've also seen people later on who are now ready to deal with the fact that they've been sexually assaulted as a child, or in recent past, or in early adulthood. So I've seen it across the spectrum, and depending on what the needs are, we just come up with a plan based on that.
That's great. So the next question is for Beverly and Sarissa, and it's, how does one implement trauma-informed care into their practice?
I think in order to deliver trauma-informed services, first and foremost, we can just make sure that we're learning ourselves and teaching ourselves and understanding the profound, like, neurological, biological, psychological, spiritual, the social effects that violence has on an individual, and how that can pass along to their families, and then the overall impact to the community. As providers, I would just stress that we all have an opportunity to educate ourselves and be able to promote protective factors that can increase resiliency, and passing those along to our patients. And then knowing how we interact with people that are in distress in a positive manner. I think learning de-escalating techniques, extremely important. Remaining really calm and in charge of the situation, but being very supportive, knowing how to listen and validate a wide range of emotions, and being able to hear that takes a lot. But I think, working with trauma survivors can also impact you, and the vicarious traumatization that you have, or the compassion fatigue, recognizing that in yourself when you're in this work, how heavy it can be, and just having that self-awareness and support. The self-care is super important for yourself as well. And then really looking at your institution and your organization. Have you created policies or services or barriers that are not using a trauma-informed perspective, which appreciates the frequency of trauma, that you are understanding the impact at the individual and community level, and making sure that you're supporting the appropriate responses. That's absolutely critical in your organization or your practice, to make sure that you're not inadvertently created those policies or barriers that are not trauma-informed. And I think there's some great resources out there that, let me see if I can share a link. I think we've used in health service kind of as our framework to go through and check some of those policies and processes that we had in place that we knew we needed to change in our organization, because they were not supporting a trauma-informed response for patients.
Sure. The whole idea behind the trauma-informed approach is resisting re-traumatization. Like, how are we creating a culture of not only physical safety, but then also emotional safety? And I think another key piece to that, Beverly, is examining our own biases as well. What are some of the assumptions that we have about individuals who have experienced sexual assault? Undoubtedly, typically an individual who's been assaulted, they have internalized some type of responsibility for the assault. So, do we have biases towards people who are addicts, or, people who are dressed a certain way, and just being aware of those biases and working through that, and understanding, that compassionate care is key. But I think sometimes, because of our own biases, we're not aware of how we come across, when working with these individuals, or we may be complicit in re-traumatizing them. So in addition to the vicarious traumatization piece, and recognizing when we have compassion fatigue, but then examining our biases, and then cultural competence as well. And just, understanding that people come from various racial and ethnic backgrounds, and the way that we approach them as well can be part of that traumatization piece, particularly if there's a difference, in racial aspects of things, or between the race of the provider and the race of the patient. Just making sure that, because some cultures, particularly African-American cultures, sometimes have resistance to healthcare and automatically have distrust, as it relates to healthcare institutions. And so just being mindful of all of those things that could impact the patient, I would say, kind of adds to that trauma-informed piece.
That's great. So we're going to move into a bit about self-care, because I will tell you that if you work in this field and you meet somebody and you tell them what you do, they automatically give you that look of like, oh no. And I could never do that. I hear that all the time, and I'm seeing some smiles of some of the panelists who probably have experienced the same thing. So in order to be great practitioners, there's a certain degree of self-care. So if Stacy could talk about ways to get over compassion fatigue, that would be great.
Sure. And, Pam, I was actually one of those people that, sitting through the Vanderbilt training, especially through the pediatric portion, I remember sitting there thinking, I don't know how these women do this. Pediatrics, I don't know. Well, I am in pediatrics currently. So it's just, I get it. It's a difficult, it's overall difficult job, right? We hear some, stories that, no person should ever have to ever endure. And I think that Beverly touched on a lot of these topics earlier. Self-care is of the utmost importance. If you can't take care of yourself, then you're not going to be able to take great care of your patients. I think that for your organization or within your practice, creating, ultimately a space where you can openly discuss things with your coworkers. They're going to be the only people that you're able to talk about your patients with. And, if they've experienced, a difficult case with you, to have that opportunity to talk about it, to discuss your feelings. Yoga, meditation, all of those things are fantastic. I think that ultimately being in the pediatric realm right now, what I try to do personally to, is just to end all of my patient visits kind of on a positive aspect when we're looking at a positive health trajectory for the patient. So for myself personally, knowing that I can focus on the good at the end of the visit, whether it be we can get them to therapy, or, that they, by offering them, that those moments where they, they know that their body is okay, and, giving them that reassurance. If you're able to provide those are the things that I focus on to, I think, overall avoid that kind of compassion fatigue, to stay in the positive all the time with my patients, to stay in the positive with my coworkers. Also, and to be able to recognize it too within yourself and your coworkers, I think, as Beverly had pointed out earlier, is extremely important. And, to always take that time. It's okay. It's okay. My favorite line sometimes is, it's okay not to be okay. It's absolutely 100% true. So, just giving yourself that grace too, as a provider, is extremely important.
That's great. So Heather, could you talk about how you help your team?
Yes, so I don't think I can say a whole lot more than what Beverly, Sarissa, and Stacy kind of touched on, but I think the most important piece is it's a very team-centric approach. So sorry, my dog's barking in the background. If you're going to get involved in this, make sure that you have pieces in play, like a mental health person that you can go to. So we have the mental health workers in our facility that take care of the kids that are there. But sometimes if I have a really trying case, I'll go and talk to them just to kind of mind dump what's in my head or what I've seen or heard. The other thing that I'll often make sure of is make sure you have a good peer review process. So when you're doing the SANE exams and you get involved in that, make sure someone's looking over your exams and what you're doing and things that you can talk to them about. Make sure again that your team is very trauma informed and having those trauma informed pieces in play. I'm always going to go back to the substance abuse and mental health and services. It's like Samahasa Association. They have a great way of implementing a trauma informed approach into your healthcare and into your team. And I think that's really important too.
Do any of the other panelists want to address self-care, talk about self-care at all? Okay. So for Erin, what do national organizations such as AFN provide?
Well, I think these professional organizations are a lot more important than I ever gave them credit when I was, going through nursing school and grad school. It felt like a broken record of people telling you to join your professional organizations, but especially in work like this that is emotionally challenging, they provide, support for other SANE nurses. They give you networking opportunities to meet other people in your field. There's continuing education and training that happen through them. Conferences, which are so much fun to go to and meet people and just spend a few days learning more things and getting more in depth, or presenting and meeting all kinds of people that do your work. I think it can, just like you were saying, we all get those looks. How do you do that? I could never do that. And that can feel very isolating sometimes. You think like, why did I choose this? Especially on a day where everything feels, really draining, or you have a really exhausting, emotionally really heartbreaking case. And then, you just kind of feel like everybody's doing everything else. And to have that sort of support, where, when you're starting to feel like you walk into a room and you're wondering if everybody in the room is an abuser, I think that definitely happens. It's definitely a sign of compassion fatigue. So having those organizations and a reminder that other people are doing this work too, and we all kind of understand what that feels like, is really amazing. And they also do public policy advocacy. They definitely, there's the Violence Against Women Act that I know that they, do campaigns for and get signatures for. So we're strong. There's strength in numbers for sure. And I think that's why we always want more of us doing this work, but you can lose sight of, when you're feeling overwhelmed and overworked, you can lose sight of how many people are really in this with you. So I think that's important with these professional organizations.
That's great. So Stacy, if you could talk about how people can learn more about becoming SANE certified or helping in other ways.
Sure. So if you are already a registered nurse and you are within a healthcare organization, most often those healthcare organizations have a SANE team or a SANE program that you can join within the hospital. Most often you go through the same training. Usually they'll recommend you to do the IAFN program, become certified. You can also go to children's advocacy centers how I received my training was through a children's advocacy center, despite that pediatrics can be a smaller subspecialty and it can be a little bit difficult. They are always, welcoming to, new people and to create new providers. You can also, if the RN role is not something that you have, or that, you'd be interested in doing, you can always be a patient advocate. You can always volunteer at your local children's advocacy centers, or, a part of any other type of organization that has a local chapter. Volunteers are so needed. We have them every day at the center. They rotate through, usually from other specialty programs like social work and other registered nursing programs. Becoming a forensic interviewer is also a great way to help. That is also a certificate program. We use them at the Children's Advocacy Center so that a child, it's a really unique, just an overall unique way to talk to a child regarding their trauma. And if you ever get the opportunity to view one of those videos, maybe online or something of that nature, it's really, how they talk to children and get them to circle back around. And it's a great tool that we use at the center. And I think that, other programs too, because we're, not just because of the COVID world, I think just because of the overall shortage providers. Telehealth, SANE telehealth is actually, kind of a very robust field that you can get into. I know Penn State Hershey here in Pennsylvania, where I'm located, they have a great SANE telehealth program, and they do a lot of trainings for nurses who are interested as well. I think that, like Erin said, it can be isolating. And like I said, I thought that this work would be more difficult, I think, than it's turned out to be, because I think just with any time that you're helping a patient, there's as much reward as there is difficulty in any of these scenarios. So if you can, focus on the good and know that it's work that's so worth doing, it's so important and needed. If it, like I'm sure I told you ladies before, this whole process has been ultimately life-changing for me. I started out at Vanderbilt with the goal to become an emergency nurse practitioner. And while I have, the fantastically wonderful twist of all of this is that I got to circle back around to the forensics, and I get to, spend my days also helping children, to, start their healing journey, and to, not focus so much on the trauma that they had once, and try to build on a positive health trajectory for them. Right now, my DMP study is it's how to use the SANE role to increase our patient population at the Children's Advocacy Center's compliance with cognitive behavioral therapy, trauma-focused cognitive behavioral therapy, because it is so important that they have that access to those services. Patients overall generally do better. They have they have a healthier life health trajectory, and it's extremely important. And anyone who's listening, I highly recommend it. I encourage it. Like I said, it can be life-changing for you too, maybe. So, thanks.
That was great. Well, I want to be respectful of everyone's time. We have reached the end of our time, but I want to thank VUSN for hosting this discussion, this panel discussion. I want to thank all of the panelists. I learned a lot, and I am very humbled to be working with all of you. I want to thank Erin and Stacy for paving the way for our VEP SANE students going out into the field and kind of being great role models for them of, maybe it may not be life-changing exactly as it was for Stacy or for Erin, but it can be a part of what they do, and they can always bring this and inform their practice with whatever lessons they're learning. So if you have any kind of additional questions, there is the email in there, and I know that they will, if you have questions for any of the individual panelists, they'll make sure to get those questions to us. So I want to thank you again, and good night.